Hello, my name is Carol Stonham. I'm a respiratory nurse specialist. I'm being interviewed today ahead of World Asthma Day to talk about the appropriateness and the relevance of FeNO testing and inhaled steroid accessibility.
What does accessibility mean in the context of asthma care, and why is it important?
Asthma is a condition where we see lots of variation in care for a number of reasons, and it might be variation in care because of the provider, it might be variation in care because of the health economics and the population that have asthma. And I think it's really vital that people with symptoms that could be asthma are easily able to access an accurate diagnosis in a timely fashion. And then those people that have a diagnosis of asthma should have equitable care. It shouldn't matter where you live, it shouldn't matter who your healthcare provider is. You should have the same standard of care provided by somebody that is trained to manage people with asthma and competent in their management, so that they're reflecting the latest guidelines and recommendations.
How would you define accessibility in asthma care, particularly concerning inhaled steroids and FeNO testing?
Accessibility is local. In my mind, it's local accessibility. So it's having the ability to access the appropriate tests in your locality. So not having to go 3 hours on a bus to get there. So it should be close by. And when we're looking at inhaled steroids, then we're in the UK, we're looking about prescribing. So we're looking about making sure that the person is prescribing knows what they're doing and puts the inhaled steroids in at the right point in the patient's journey, which is right at the start now. And when we're talking about FeNO testing, again, it can be that FeNO is put in little pockets in hubs, and it means that patients have to travel quite a way to get there, and that isn't right for all patients. If you're lucky enough to be in Gloucestershire, we have FeNO at every practice, so everybody is within a close range, if you like, of being able to access the test.
How can healthcare services ensure that asthma medications like inhalers are accessible to all patients, regardless of their background or location?
Within the NHS, I think it's different to the rest of the world. So within the NHS, we have the ability to prescribe inhalers. What we don't have is every patient with asthma coming in for a review and every patient with asthma being on the right medication to control their symptoms. So what we need to think about is how we access patients that wouldn't normally access our services. Sometimes that might mean offering a clinic on a different day, offering a weekend clinic or an evening clinic. And sometimes that might mean taking care to that patient. And in the UK with the National Health Service, we can do that. So we can go into schools, we can do different things. I think when you're looking more broadly across the world, there are different challenges. So when you look at private healthcare, then cost comes into it far more than I think we consider that within the UK.
What are the current barriers to accessing ICS medications and FeNO testing?
They're two different things. So the barriers to accessing inhaled steroids, I think, are more around patient education, well, actually around healthcare education and patient education. So understanding the inflammatory nature of asthma, understanding what asthma is, and understanding what inhaled steroids do and why it's really important to take those. So I think that's one issue. There's also then the issue around how do people access care. So if we have patients from different ethnic groups, maybe they're not as keen to access care. If we have patients that are from areas of poverty, for example, we know those people don't access care. So I think we need to think about that. I think accessing FeNO testing has the same challenges, but is slightly different in that we know that across the UK, there is still not enough FeNO testing out there. So it should be close to the patient. In Gloucestershire, as I say, we have it at practice level, which means that where your GP is, you will be able to get a FeNO test. In some areas, there's no FeNO testing, and we're talking UK. In other areas, it might be at PCN level, so it might be that 5 or 6 practices have one machine that they share, and that might mean the patient has to travel to the machine, or it might mean the machine has to do a little round. But that makes things complicated. If the machine is where patients access care, so if the machine is at the GP surgery, you can do it when you need to. It's not, you don't have to think about where's the machine today, where to have to refer the patient to. So I think it is around getting people to access care, making care easy to access, so that we can offer appropriate testing and medication as and when it's needed.
From your perspective, what steps can healthcare services take to improve access to inhaled steroids and FeNO testing for asthma patients?
So with regards improving access to inhaled steroids, I think the first thing we need to look at is healthcare professional education. If you are somebody that doesn't really understand asthma, that maybe does the course review and ticks the boxes, but hasn't had the asthma training, then understanding where in the pathway asthma sits isn't necessarily your forte. And recognition that a patient has worsening control or inappropriate treatment doesn't happen as much as it should. So I think the first thing is around healthcare professional education. It's a real shame we can't set a standard and say everybody that does asthma reviews needs to have this level of training, for example. I know the Primary Care Respiratory Society have got a really good document out. It's called Fit to Care, and it looks at exactly that. So if we could initiate that across the country, that would be fantastic. So that would be the training sorted out. There's then the bit around when guidelines change. So our UK guidelines changed in November, and they were big changes. And it's getting the message out to those people that don't have a particular interest in asthma, but see patients with asthma. So in primary care, it is general practice. It is a bit of everything. And it may be that you see a bit of everything. It may be that you're the diabetes specialist, for example, but you see the odd asthma patient. So it's getting that message out across the whole population. And I think once we get that bit out, the next bit follows nicely. So the next bit is around patient education. So it's around getting patients to understand their disease, to understand what their treatment does and how it works. And therefore, they'll be more confident in self-managing. So they'll be more confident in adjusting medication as and when they need to. And really importantly, seeking help when things go wrong.
Could you explain the role of FeNO testing in asthma management, especially in conjunction with inhaled steroids therapy?
So FeNO testing has a few really important, in my mind, really important parts to play. So firstly, when we look at diagnosis, I was absolutely delighted when the guidelines changed in the UK that FeNO was the initial recommended test, because to me, asthma is a disease that causes eosinophilic airway inflammation, and FeNO is a test that detects that. So why wouldn't you do it? To me, it's very logical. So I think that is the first thing, is around getting the diagnosis right. When the diagnosis has been made, you don't just put your FeNO device to bed, because there are points at which it is really important to be able to have access to that test. So I previously ran a primary care-based referral clinic where the criteria for referral, and I think it covers nicely what FeNO can do, was firstly around diagnosis, secondly around patients that were symptomatic and needed a change in their medication, thirdly around patients that were poor adherers to medication, and fourthly around patients that didn't understand the disease at all. And primary care don't always have as much time to explain things. And I think those four places are where you can really use FeNO. So clearly around diagnosis, secondly around titrating treatment. So going back to the eosinophilic airway inflammation, if you have the airway inflammation under control, you don't need to work on that pathway anymore. You're looking at twitchy airways, bronchospasm. However, if you have a patient on a combination inhaler with an inhaled steroid and a long-acting bronchodilator, and the patient is still symptomatic, the guidelines now tell us to do a FeNO device, thank goodness, to do a FeNO test, simply because you need to know whether we need to be working more on the inflammatory pathway, so we need to be thinking about maybe biologics, or whether or not it is the twitchy airways and we need to add something in along those lines. So that absolutely makes sense. The guidelines also say, and I've been saying this for a very long time, that if you have patients that are poorly adherent to treatment and or don't understand their disease, and the two tend to go hand in hand, if you can help a patient understand their disease, then they are more adherent with medication. So what we always do is we use various diagrams, we draw little circles, we show patients the airway inflammation, we explain it to them. But if we can then do a test to measure it, it's like when you know you're a bit overweight and you get on the scales, you can't deny it. If you do a test to measure the airway inflammation, then patients get it. It's like a light bulb moment. They absolutely get it. And likewise, with patients that are non-adherent, again, if you explain what asthma is, explain what the treatment does, explain what you're going to measure, and then generally my sort of question is, you're on a good amount of medication, yet you're still symptomatic and I don't quite get it, so this test will tell us what's going on. Then they realise that you're going to know that they're not taking the medication, and before you've even done the test, they usually start saying, oh, I forgot my medication this morning. So it gets you into that whole non-adherence conversation, which is really important.
What benefits do patients gain from combining FeNO monitoring with ICS treatment plans?
When you're starting a treatment plan, if you are able to measure inflammation, so you can tell the patient they've got it, if you measure inflammation, explain that the medication is going to get that under control, and then get them back later to check they're taking their inhaler and measure it again, they can see that their medication is working. And I think it's something about actually having confidence in a medication that you can't feel working, doing its job. If you have patients on inhaled steroids on their own, when you take an inhaled steroid, you don't feel anything happening. And patients aren't told that that's the case. So they think, oh, it's rubbish, I'm not taking that, it's not working. So they stop using it and they go to what they like, which is a bronchodilator, which is absolutely not what we want them to do. So it is around, as I say, it is around demonstrating the inflammation and then showing them that their treatment is working. Absolutely showing them the treatment is working.
How can healthcare providers effectively integrate FeNO testing into routine asthma care to optimise treatment outcomes?
It's easy to do that. It's so easy to do that. The test is so quick. So if you have a 10-minute consultation or a 15-minute consultation, if you're talking about doing something like spirometry that takes a long time, you cannot fit it in. It doesn't fit. A FeNO test takes minutes to do. Most patients will get it first time, so it takes about 12 seconds in all honesty. If they take 2 or 3 attempts, you're talking less than a minute. So I think the actual practicalities of involving it within routine care are not a problem. The problem is actually having access to the device and access to the consumables. So it's around the finance and the costing of that. In Gloucestershire, we are really lucky in that we, as I say, we have FeNO at every practice and we pay a local enhanced service fee for them to do diagnostic testing. So if they do a diagnostic test, they get paid, and that then pays for the next lot of consumables. So it's getting a system like that up and running in some way where you can have a setup for the programme, but also have some sort of planning for the future so that it is sustainable in the longer term.
Can you share a personal experience where using FeNO for asthma management has benefited you as a healthcare professional?
Yes. So what I say now, and a lot of the nurses in Gloucestershire that are using FeNO now say, is if they don't have their device, they feel like they're working with one hand behind their back. So we know what asthma is, we know how the treatments work, but when we see a symptomatic patient, we have to best guess the direction. So we have to guess whether or not the patient is using their inhaler, we don't guess about inhaler technique, we absolutely check inhaler technique, but they'll often do it in a perfect way in front of you, and then when they go home it's all wrong. We have to guess which part of the treatment pathway needs titrating up. So if a patient's symptomatic and they are on just an inhaled steroid, what we do is we add in a long-acting beta-2 agonist. Well, if the inflammation isn't under control, that's not the thing to do. So what FeNO does is it tells you what to do next. So if a patient is symptomatic and they have a raised FeNO, then you know that you should be thinking about adherence to medication, inhaler technique, triggers, so seasonal triggers, new things at home, things like smoking, and then actually that's the bit you need to increase. You need to increase the anti-inflammatory treatment. If a patient is symptomatic but their FeNO is low, then that's not the thing to do. It is absolutely the right thing to add in maybe a long-acting bronchodilator or maybe montelukast after that conversation, still around triggers, around adherence, around all of those types of things. So instead of best guessing, you've got a more scientific, more planned direction in treatment pathways. It's not going eeny, meeny, miny, mo. It's actually saying, right, logically, this is what we need to do.
What innovations or initiatives have you seen or been involved with that aim to enhance accessibility to ICS medications and FeNO testing?
With ICS medication, I think the change in the guidelines is fantastic. So the latest BTS NICE sign asthma guidelines that came out in November say that no patient should be prescribed a bronchodilator medication without an inhaled steroid. Very strong statement. We have a lot of patients that are on just short-acting beta-2 agonists and no other medication, and the guidelines absolutely tell us not to do that now. They say that they should be at least on a combination of an inhaled steroid and a fast-acting, long-acting bronchodilator, so formoterol. I think that will make a huge difference to the way we treat patients, and it's a real turnaround in the recommendations. They also recommend that when we have patients that need more regular therapy, so PRN, so as needed formoterol with ICS is called AIR, so it's anti-inflammatory reliever therapy. The next step is MART therapy, so that's maintenance and reliever therapy. So all of those, all along the pathway, have all got inhaled steroids in. Nobody with asthma should not have an inhaled steroid in the UK. So that's a really big step in the right direction. It is getting that knowledge across to healthcare providers, so it is making sure they're up to date with the most recent guidelines. And I've been doing locally and nationally lots of education, as have a lot of other people, to try and get that message out there to make sure people are doing the right thing. With FeNO testing, it is different. So I think the guideline recommendations around FeNO are fantastic as well. So they're saying you have to have it for diagnosis, and when you get to a certain point in the treatment pathway, you should do a FeNO test to decide on the next step. So I think they will push people towards making sure they've got accessibility and they've got local accessibility. The other thing is around making sure that it is sustainable. So thinking about the consumables, thinking about service if that's required, those types of things. So it is around having a local enhanced service or some way of making sure that the people that are using the FeNO test, which should be practices, have some funding stream to maintain that. And we are seeing more and more people, more and more ICBs going along the route of actually putting a local enhanced service in place to pay for respiratory diagnostics. And it will absolutely make a difference to the number of tests that are done in the right place.
Are there any specific regions or demographics that face greater challenges in accessing these asthma management tools, and how can these be addressed?
We know in the UK that the patients in the lower socioeconomic groups don't access healthcare, so they tend to be more difficult to get the information to and the testing to. Again, I think there's that thing around accessing healthcare so that they get a FeNO test is one thing, but if they're just on that cusp when they don't get free prescriptions, it's then actually affording the cost of the prescription and the medication to take that. So I think being aware of the differences in socioeconomic groups, absolutely. Differences in ethnic groups. So in some cultures, it is thought to be a weakness if you've got some sort of long-term condition. So I think it's around getting messaging out to those types of communities. We're moving towards neighbourhood delivery of healthcare. So making sure that services are planned on a neighbourhood basis to suit their populations. And I think that is the way forward. I think one size doesn't fit all. Having a whole blanket of this is what we do for everybody is not going to be the right way. It is around knowing your population and knowing how to tackle that population. In inner city Gloucester, they have done some fantastic work. They've got lots of stuff going on. But as an example, and it is slightly off, but it tells you what you need to be doing. They had a problem with smoking. They've got a big Polish, Romanian type population, and they had high numbers, very high numbers of smokers. And it was because the populations didn't realise it was bad for their health, and they'd never been told that. So they had a Romanian receptionist, and he trained to be the smoking advisor because he speaks the right language. And it's absolutely turned around what's happening with their populations and encouraging them to access healthcare. So it's around making sure what you provide is local for your population.
Looking ahead, what changes or improvements do you think are necessary to ensure that asthma care is truly accessible to everyone?
The biggest thing is funding. I have said for many years, if FeNO testing was free, everybody would do it. The difficulty is who pays. So currently there's a difference in funding in the UK for definite. So in some areas, the ICB will take responsibility and say, this is important, we will pay for it. In the majority, that isn't the case. So in the majority, then you're coming down to PCN level. And within a PCN, is it a PCN-wide priority? If the PCN themselves don't see it as a priority, then you're coming down to practice level. And in the UK, general practice are independent contractors that contract to the NHS, so they're independent businesses. So if they want to invest in something like FeNO, it is out of their funding. And I think what we need is a strategy that goes across everybody, that the ICBs are the people that take responsibility and make sure that funding is available and FeNO is available for their populations, whatever their populations are.
How can collaborations between healthcare providers and advocacy groups further improve access to these essential asthma management tools?
Asthma and Lung UK do a lot of work on this. So Asthma and Lung UK are very proactive in they've just released a report looking at spirometry. So they didn't look at FeNO, sadly, but they looked at spirometry. And they looked to see how accessible spirometry was and whether there was enough capacity to meet demand. And it was a very variable picture. And they put together a really strong report on that. And that is something that can't be ignored. So when it comes from a big patient organisation, it can't be ignored. So I think that's one of the ways forward. The other thing is the Task Force for Lung Health. So the Task Force for Lung Health is a collaboration of 50 different respiratory type organisations. And there is an early and accurate diagnosis group within the Task Force for Lung Health. I'm one of the co-chairs of that. And we are trying to campaign for equity of access for all respiratory tests for all patients. And I think those groups have got very strong voices. The difficulty at the moment is the financial and economic climate that we're in. There is no money to do anything. We're being told to spend less. But it's around making sure that you can demonstrate the cost effectiveness of an intervention, not just the cost. And I think we lose that a little bit in translation. So it tends to be, it costs too much, not, but it saves here, here, and here. So it's the whole cost-effective picture that we need to be helping those campaigning organisations to realise.
To anyone thinking of incorporating FeNO testing into their primary care or secondary care settings, why would you encourage that?
It's that whole thing about having the whole thing for the whole picture for the patients. I think with the guidelines now, you can't not. You can't implement what the BTS NICE sign guidelines are telling us to do if you don't have access to FeNO. The guidelines are evidence-based and have cost-effective modelling within them. So we are being told by the British Thoracic Society, SIGN, which is the Scottish organisation, and NICE, importantly, that this is what we should do because this is cost-effective. And I don't know how you do that if you don't have a FeNO device. From a more practical point of view, as I've said, I think having a FeNO device is fantastic for the healthcare provider because it helps you to demonstrate what is going on with the patient. It also helps you to think more logically about titration of doses and changing the medication, but it's also a vital tool for the patient. So it is that thing around the light bulb moment for the patient with them getting it. And they then become less demanding on healthcare resources. The thing we are really short of in healthcare is time. So these patients that keep coming back and coming back and coming back because they're not taking the medication because they don't really understand why, those are the ones you can absolutely turn around and free up time, which is the important factor.